Welcome to the conference session titled PNH Non-Transplant Therapies. Thank you for joining us. My name is Nkirika Ashadu, Program Content Manager, and I will be moderating the presentation today. As we get started, we want to recognize the generosity of our corporate sponsors as well as patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. One, submit your entire question all at the same time. Two, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Alex Nestor. Dr. Nestor is an assistant professor of medicine in the Division of Oncology and Hematology in the Department of Internal Medicine at UNMC. He completed medical school at the Sanford School of Medicine at the University of South Dakota in 2013 and his residency in internal medicine at the University of Nebraska Medical Center in 2016, as well as a fellowship in hematology and oncology at the University of Nebraska Medical Center in 2019. His clinical interests include benign hematology, sickle cell disease, and bleeding disorders. With that said, welcome, Dr. Nestor.
Thank you all. I'm Alex Nestor. I appreciate you guys having me here. I'll try and I try and not be too particularly focused on scientific things, particular numbers. I just want you all to appreciate kind of an overall understanding of how we treat PNH and such. I'd rather you kind of appreciate how this disease works, and that can kind of help solidify how we use our treatment and how our treatments are effective. That's my objective. We'll be talking about, again, I think how we diagnose it, and then also kind of the mechanisms of that and how we stop those. I don't have any financial disclosures to give to you at this time. So we set this up as part of a bone marrow failure syndrome, although PNH is kind of a particular case. It has a very distinct mechanism, which we're able to get a lot of good data and understanding about, which makes it kind of a more fun or interesting disease in a lot of ways for hematologists like ourselves. There are still a lot of mysteries about PNH, and I'll kind of go in on those a little bit, and other further areas for research. In general, paroxysmal nocturnal hemoglobinuria, or PNH, is considered a very rare disorder. 6 per million or so, and so that's maybe a third of or less of patients with bone marrow failure syndromes. It actually does appear in younger patients. The median age is approximately in their 30s or so. Unfortunately, because PNH doesn't really present itself sometimes in the most clearest fashion, it can sometimes have substantial delays for diagnosis. Oftentimes patients may have symptoms or lab evidence of PNH for a number of years, but unfortunately, unless we're specifically looking for it, it can be pretty easily missed, especially in more milder cases, and we'll talk about that. One of the main features of PNH and how it affects us clinically is hemolysis. So this is oftentimes one of the presenting features of PNH. The red blood cells are destroyed directly in the bloodstream. This is kind of important because in a lot of other ways of hemolysis or red blood cell destruction, this can sometimes be done outside of the bloodstream where the cells are plucked out by the spleen or other immune organs, and then they can be kind of dismantled in a more orderly fashion. In PNH, this hemolysis can occur directly in the bloodstream, which causes a lot of the intracellular materials from things like red blood cells to actually go through the bloodstream, and they can cause effects themselves. So not just the hemolysis, which will cause some anemia. Generally, the anemia is mild to moderate, usually with a hemoglobin of maybe 9 to 8 grams per deciliter, which is certainly enough to make someone tired and would be clinically noticeable. This can progress to the point where it becomes transfusion dependent. The notion of hemoglobinuria is kind of the interesting part of where this gets its name. Because of this intravascular red blood cell destruction, the red blood cell molecules, the hemoglobin, can actually filter out into the urine, and then that creates kind of a darker tint to that urine, especially in the morning or in the middle of the night. This can occur seemingly randomly, which is why we call it paroxysmal, or occurring randomly and suddenly. Nocturia at night and hematuria does come up in the urine. Most of medicine is just using really fancy words for concepts that we all kind of understand, so it's not way out there. This intravascular hemolysis can cause some additional effects that we don't just see with anemia. Certainly patients who are anemic can feel slow, sluggish, tired, short of breath. But because this is, again, an intravascular process, patients can also have other issues where they may experience fever, back pain, general malaise, and also can have substantial jaundice, scleral icterus, and yellowing of the skin. Again, we can sometimes treat this hemolysis by using transfusions, but we know that there are some risks to that therapy as well. Another major component of PNH is thrombosis, or the accumulation of blood clots. A researcher was quoted as saying, "We can safely say that PNH is the most vicious acquired thrombophilic state known in medicine." This is a major cause of mortality in PNH patients. 40 to 50% of patients can experience a blood clot in their lives. And oftentimes this can be a cause of the fatality, where a blood clot is so massive that it causes organ dysfunction and can lead to death. The mechanisms of why these blood clots occur is not entirely known. We know that things like inflammation can cause people to be more likely to form blood clots. Say after a surgery or a car accident, we would have an increased risk for things like blood clots, acute illnesses. But also PNH affects some other cells too, including platelets, which we know are associated with blood clots, and they may actually be more active or even younger, which can increase their risk for thrombosis. Granulocytes, or the white blood cells, can also be affected and more activated. And so it's thought that that extra inflammation from these granulocytes can also cause thrombosis. This can also actually occur even when our burden of PNH, and we'll talk about that a little bit more, can even be quite low. So even though you may not have PNH-like symptoms or PNH in all of your blood cells, even in those kind of subclinical populations of PNH can still start to develop some of these thrombosis. Interestingly enough, these are often thrombosis in atypical locations. Hematologists are very, and general medical professionals are usually very aware of common places for blood clots to occur. Things like lower legs, especially when the blood is kind of pooling in there. Lung clots or pulmonary embolism is, again, pretty classic. PNH certainly can cause that, and we do have an increased risk for that. But we do see some more interesting places for thrombosis, including the cerebral vein thrombus, where you can have a blood clot in the vessels that are trying to drain out the blood from the brain. That can cause headache, mental status changes, and needs to be treated pretty quickly. And then also it can increase the risk for visceral thrombosis. And that's a blood clot that might be sitting either ahead or behind of the liver, which can cause issues with your intestinal tract, your spleen, or if it's in blood right next to the liver, it can actually cause liver failure in something known as Budd-Chiari syndrome. Additionally, dermal veins can also be found to have thrombosis, and so PNH can actually cause a substantial amount of necrotic changes to the skin. Usually we just treat this with anticoagulation, and oftentimes we keep this chronic. But recommendations for anticoagulation in PNH are still a bit debated. Not everyone with PNH is going to get a blood clot, and so oftentimes providers will not put people on a blood thinner straight ahead. On the other hand, people who maybe have presented with a blood clot, we've identified the PNH, and once they're on therapy, some will talk with their provider about coming off the blood clot. But in general, we put people on blood thinners such as apixaban or rivaroxaban. Diving into kind of how these happen, I'd like to explain the complement system a little bit. This is kind of a difficult conceptual model that we see. We're familiar with how the immune system generally works. We have things like granulocytes or neutrophils that go out and cause inflammation. Those are cells. We also have B cells, T cells, which are much more specialized. And then interestingly enough, nature has given us this complement system. These are small proteins that are always circulating around in the blood and can randomly or through various triggers cause a reaction that can start to destroy cells. This is a process where these different proteins have to tap each other on the shoulder to activate themselves. And there can be a number of different triggers that can actually cause this cascade to occur. That could include antibody binding, where pathogen has already been targeted. Antibodies can then help the complement system attach itself to that cell membrane. Bacterial sugars, the complement system can sometimes actually hunt out some changes to the bacteria that make them look distinctly not like us. And when they find those sugars, then they're able to bind closer and can help destroy certain types of bacteria. And then also the complement system itself is always kind of on the edge of activating itself in the alternative pathway. There are a bunch of other regulatory proteins, such as factor B, factor D, which try and decrease the likelihood that the complement system is going to engage itself. Especially in times when there's inflammation or tissue damage, the complement system is much more likely to be activated. And it's thought that when you're sleeping, then potentially because you're not breathing quite so much, there's a little less oxygen, and that may be why people have some hemolysis when they're sleeping. So kind of to run through that, again, that classical pathway is where the complement system can bind itself to an antibody specifically targeting a cell. The lectin pathway, those are those sugar molecules that will sit on the outside of a bacterial cell. And then the alternative pathway, which is where these proteins are automatically activated. I think a way that I've kind of conceptualized this myself is almost like they're little landmines, or they kind of form bullet holes, if you will. Once this complement pathway is activated, especially through C3, that can then start up down. If we follow down between the C3 convertase, it combines down to C5 at the very bottom there. C5 then can bind to the outside of the targeted cell. It then pulls in a whole bunch of these other proteins that have been circulating around in the blood, and actually forms what's called the MAC, which is a circular port that essentially just has all of the insides of the cell end up pouring out. It's very bad for bacteria, but unfortunately, because this is happening in circulation, that's also why we see this hemolysis occurring inside of the vascular system. One of the important ways that the body protects itself from this complement system is through the use of these proteins, CD55 and CD59, or decay activating factor, and the lectin response decreaser. What these do is they go in and they grab that C3b and prevent it from attaching that C5 onto the cell. These are proteins that we actually have identified, and we can actually target them, and we can identify them through something called flow cytometry. The genesis of PNH is when we understand that this PIGA gene, of which you have 2 copies, gets modified or deleted, which then causes this CD5 and CD59 to no longer be created. This then makes it more likely that these cells are going to be attacked by that complement system. These are oftentimes cells that are very, very high up in that hematopoietic stem cell change, and so we call it clonal because all of those children from those initial cells are going to have that defect. Flow cytometry, again, is a very common laboratory tool that we use for many hematological conditions. Essentially, we have many different white blood cells and red blood cells, and we've identified little proteins on the outside that we can actually distinctly label with maybe a small fluorescent probe. And as the cells pass one by one, lasers or electric pulses can kind of separate these cells and can help us identify abnormal populations. So, for example, a flow cytometry of PNH is going to show a loss of the CD59. You can see that little pop up there. Once we've done that flow cytometry, we can also get a quantitative amount of how much, how many of these cells, what percentage of them are actually affected. Different cell types can sometimes be affected in different ways. You could have granulocytes that are more effective, red blood cells, or platelets. And oftentimes we give that as a percentage. That could be greater than 50% of all these cells that are activated, or can be detected in very, very small quantities, 1 cell per 10,000 or less. And as we know, those are associated with bone marrow failure syndromes as well. We also will do a bone marrow biopsy. However, in aplastic anemia, the major issue is that the cellularity of the bone marrow biopsy, these precursor cells, start to disappear and are often attacked and then replaced by adipose and fatty cells. On the other, and this can happen in a lot of cases with PNH, especially with those lower clonal populations, in which case we have that bone marrow failure syndrome. On the other hand, if the issue is more that these cells are lysing and being destroyed, the body has to adapt by increasing the amount of cells that it's able to pump out at a given time. So while a bone marrow biopsy that we would be looking for something like aplastic anemia is going to show very few cells, a patient with PNH may actually show a substantial larger number of these hematopoietic cells and cells that are kind of trying to graduate and help replenish the ranks, if you will. Interestingly enough, there are generally not an increase in blasts. Those are the very smallest hematopoietic cells, or kind of the most primitive, and we don't see that, which is usually more indicative of something that would be concerning for like a leukemic process. So the hematopoiesis does increase, but it is still relatively well ordered. It's not overpopulated by any particular type of cell. We can categorize this PNH in a couple different ways. Again, depending on how much of the cells we see have the particular defect, a very, very small percent may be more associated with the bone marrow failure. Many patients may be kind of sitting in the middle, the subacute syndrome, where they may or may not have substantial amounts of hemolysis or other symptoms. And then on the other hand, if that PNH population can increase, then you're going to have higher risk for symptoms and whatnot. These clones can change. We're not entirely sure exactly how PNH is able to continue to expand itself, because we're really considering that this initially starts with a small population of cells that have this defect, and then over time they may start to take up more and more of the younger cells. It's thought that maybe PNH cells are more likely to evade immune destruction. Others say that PNH cells may be more likely to proliferate. But again, these mechanisms are not fully understood. If we're citing into that bone marrow failure, generally we would kind of treat this as the way we would for aplastic anemia, which we just kind of talked about, immune suppression, L-thrombopag and such. For those kind of more subacute cases, oftentimes we'll do supportive transfusions. And for a long time, our real options were transfusions and trying to help assist with the body recovering from all that hemolysis. But also the other possibility is allogenic stem cell transplant. Of course, getting transfusions has its risks, so iron overload, and we might have to put people on iron chelation. And those medications we know are increased with a risk of auditory damage, liver toxicity, and such. The major way that we have been attacking PNH is the development of complement C5 antibodies. Eculizumab was a breakthrough. So this is an antibody that directly targets CD5 and prevents it from actually binding on that cell surface. As such, it's not able to pull in that MAC, provided it's through that C5 pathway. Eculizumab is an infusion treatment. It requires dosing after a loading period of every 2 weeks. And more recently, ravulizumab has been on the market as of 2018. This works very, very similarly to eculizumab, in which it still targets that C5 pathway. However, those antibodies are recycled, and so it allows for decreased amounts of dosing. People might have to come in and get their infusion only every 8 weeks or so. But they're still both considered kind of our frontline treatment. We see that again decreases hemolysis and also decreases that thrombotic risk. More recently, we have new C3 inhibitors. The issue being that C3b, its own little molecule, can sometimes attach antibodies and cause that extravascular hemolysis. So we don't have that MAC process where the red blood cell is kind of stabbed and starts to pour out its innards. Instead, the C3b binds onto the cell surface, and then other antibodies can bind to that, and then it can be opsonized or phagocytosed. The issue is that when we're blocking C5, we're still leaving this C3b alone. And so pegcetacoplan is very recently released, and this actually binds to C3. This is not an antibody. It's actually a protein that has a pegylated molecule in it that allows the protein to kind of stay in the body. And interestingly enough, this actually doesn't need to be an IV. It's a subcutaneous patch that just slowly releases the medication that needs to be applied about every 2 weeks. It does show that pegcetacoplan does seem to improve the mean hemoglobin level in its various patients. And then we also can use these medications in other complement-dependent diseases. There are other activations of the complement process that can cause renal disease, and so we still will use these. It's also used in some autoimmune neurological disorders and also macular degeneration. The biggest concern with these therapies is the infection risk. As we talked about, that C3 and C5 activate that lectin pathway, those abnormal bacterial sugars. Those polysaccharides encode certain bacteria, and they make it much harder for our immune system to recognize them and destroy them. When we get rid of that complement pathway, then that kind of allows these microbacteria to be a lot easier to cause severe disease. In particular, this is we majorly worry about Neisseria meningitis. This can oftentimes be rapidly fatal. It comes on quickly, usually with some form of headache, some kind of fever, photosensitivity, and neck pain. And then there are also some other encapsulated organisms such as Salmonella, Streptococcus, but those are less likely to be our major problems. We have to vaccinate against meningitis, ideally a number of weeks before we give the eculizumab or other complement inhibitor. And then oftentimes we'll put people on a prophylactic antibiotic just to make sure that they're well covered, especially during the beginning parts of therapy. Even still, part of the high-risk medication management does require that we have patients be aware that should they start to develop a fever, they should present themselves to a hospital. And depending on where a patient might be located, such as if they might have less access to an emergency room, we may actually have them have a bottle of antibiotics on hand just in case they were to develop a fever and they knew that it might be an hour and a half or 2 hours before they can get medical attention. We're still working on additional therapies. This would include some oral complement inhibitors. Iptacopan, this actually goes back and increases that factor B, which again we saw originally decreases that activation of C3 and C5, including with their antibody binding. So this may go back a little bit. This actually is being studied with eculizumab. The notion being that the eculizumab can still take care of that C5, while the iptacopan with the factor B is going to decrease the activation of the C3. And again, hopefully prevent that extravascular hemolysis as well. And then similarly, danicopan increases regulatory factor D as well. All right. Well, again, PNH is a very special subtype of bone marrow failure syndrome. It can be associated with aplastic anemia, especially with small clonal populations. In small clonal populations, we'll oftentimes use just supportive transfusions. In high-risk folks, we'll oftentimes push for a stem cell transplant. But for many, many patients, especially when they have that classical PNH, high amounts of hemolysis, greater than 50% of PNH clones, then we would reach for our complement inhibitors. But again, they do have their risks of infection, and we're still looking for other ways to inhibit the complement pathway. Other ways that we're still investigating might be different ways to identify PNH clones early and trying to figure out how they are propagating through the bone marrow, but more research is needed. That was pretty quick, but I just want to know if anyone has any questions. Yes, sir.
Let's say you're diagnosed with PNH. What's the current survival rate? And I realize that it's different from a young person to a middle-aged person to an older person. Even with, I was on prednisone and Danacrin many years ago. So, sorry. And I just was curious as to, is it always eventually fatal PNH, or has it been managed for long periods of time? And is that danicopan, is that related to the Danacrin that they used to use? Is that a similar
I
steroid?
don't know. No, it would not be a steroid-based. No. The survivability of PNH has improved dramatically with these. We're not so worried about the transplant-associated issues. It helps with the thrombosis. So it is becoming much more of a chronic condition. I think that's one of the reasons why there is this kind of push to try and find more chronic, manageable solutions as opposed to frequent infusions. Additionally, these medications have a substantial cost burden. I remember when I was in medical school, eculizumab was proudly said to be the most expensive medication on the market at the time. Eculizumab, the first one. So it is much more survivable. Again, once people are doing well on these inhibitors, we may even kind of hold off on discussions about transplant at this time, as long as we're being mindful of things like infection risk.
Transplant is an option for PNH in addition to plastics.
Sure, yes. Especially in folks that have the PNH that sides a little bit more towards the bone marrow failure. And so oftentimes while we're following PNH, we'll actually try and watch that cellularity. Patients with good cellularity are going to be able to continue to make their own cells, and so we could continue them on that complement pathway. But if we start to see decreases in their cellularity, then we might have to discuss transplant.
And I have some questions from our Q&A online. One of the questions is, can a bone marrow biopsy have different results depending upon the location where the biopsy is taken from?
That's a rough question. Rarely. I would say that generally these are kind of found throughout. Additionally, one of the important things is that flow cytometry is looking for circulating cells. So I would say that these PNH-affected cells are kind of throughout the body, as opposed to kind of a localized population. In a lot of other disorders, plasma cell dyscrasias, things like multiple myeloma and whatnot, you could have a collection of these abnormal cells that are just in one place. PNH, on the other hand, is generally going to be much more uniform. I'm not usually concerned that one area may be more hypercellular than another. It tends to be pretty uniform.
Okay, and another one of our questions is a patient who said they are on dialysis. Did PNH cause their kidney problems?
It certainly it can, yes. The intravascular hemolysis can be damaging to the kidneys. Additionally, the complement cascade, when activated, can also damage the kidneys, oftentimes in a different associated condition, complement-associated thrombotic microangiopathy, such as atypical HUS, is usually what we associate with kidney failure in those cases. Those generally won't show that PNH clone, however, so it can be a different process. But with enough hemolysis and hemoglobin impacting the kidneys, it certainly could impact it.
And another question asks, can you go into more detail regarding the difference between danicopan and ictacopan processes?
Largely they're both kind of hitting on this alternative pathway just on different areas. That CF, that complement factor H, complement factor B, both of those are the complement factor D and factor B are both able to kind of induce that C3b changes. And so they do both work pretty similarly, just in different parts of that process.
Thank you, Dr. Nestor, for sharing your time and expertise with us. If you would like to watch the session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay or navigating the on-demand tab in the platform hub. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. Also, be sure to visit the exhibit hall and chat with the conference sponsors. What we're going to do is continue to ask questions, and the questions will be for Dr. Tantravahi. So we have some questions for you as well.
Thank you. Yeah, go ahead.
All right, so our first question is, after ATG, how long is it before a patient will see a response?
That's a great question. So it typically can take several weeks. The reason behind that is that if you remember when we were talking about how patients develop aplastic anemia, the immune system is attacking the bone marrow stem cells. But when you try to cut that off with ATG and then with the tablet cyclosporin, the bone marrow stem cell still has to recover. They've been under attack for a very long time, so now they have to have the job of setting up the shop again and start producing cells. So in general, I do not call that the treatment failed for at least 3 months, and if not, up to 6 months. But what is important is that early recovery is often a good sign. What that means is that if I start seeing an improvement in white cells, especially the neutrophils, the infection-fighting cells, or the hemoglobin on the requirement in transfusions in the first few weeks, after about a month or so, and then it progressively continued to get better. If you remember the graph that I showed you, the blood counts don't shoot up next day. It's a very gradual climb over time. So it's important to recognize that and keep track of it and not consider that the treatment failed too soon.
Okay, and I'm just going to go between questions for the both of you. This question is for Dr. Nestor. What caused breakthrough hemolysis with PNH if a patient is on treatment? What are the options for this patient?
Breakthrough hemolysis has been seen a little bit more often in eculizumab or Soliris, less so in our newer, longer acting. That may be because of different levels of the antibody that's circulating. Or additionally, you said Intravascular or extra? Breakthrough. Well, the major issue is that, again, like we saw, even when we're on those CD5 inhibitors, we can still have some degree of hemolysis happening just through another pathway. And again, that's one of these reasons why we're starting to look at newer therapies that block at a higher level.
Okay. And my next question is for Dr. Tantravahi. This person asked, sorry, I'm scrolling down. How many times can ATG treatment be repeated?
Yeah, again, very, very good question. So typically, there's not like a specific number. So we have two forms of ATG. One is horse ATG and rabbit ATG. If someone has an excellent response, say, for example, to horse ATG, and then maybe about a year later, the disease come back, then I would consider retreating with horse ATG. And we're talking about these patients who are not necessarily transplant candidate, or there's no donor available for them, or they're too either elderly or other health problems to go through transplant. So you can repeat the same, especially if they've had an excellent response. And then sometimes you can also switch to the different form of ATG. And that can be in a situation where you have a response to horse ATG, but it didn't last very long, only last maybe about 6 months or less than a year. Then I have more inclined to try rabbit ATG. But after, I've had patients, a young patient, for example, who surprisingly didn't have a single donor in the registry, and the siblings weren't a match, and this patient received numerous ATGs. And then after a while, we can also use different forms of oral immunosuppression. So the cyclosporin is probably the most effective drug of all, and we try to get better by using different drugs and different combinations. And so far, none of the drugs as effective or as well tolerated as cyclosporin. So we use other forms of immunosuppressive drugs. Say, for example, there's another drug called tacrolimus. So there are other choices if we need to continue to maintain immunosuppression. And the other thing also is that stopping immunosuppression often can cause relapse of the condition. So for a fair number of patients, I keep them on low-dose cyclosporin to keep things under control and maintain blood cell production.
Thank you. This question is for Dr. Nestor. When should a patient with PNH start treatment? Is this based on clone size?
It's actually with a number of different factors. Hematologists love numbers. And so we'll oftentimes use some of the indices of how severe the hemolysis is. For example, if a patient has a very, very high amount of LDH, which is another protein that's inside the red blood cells, if that's markedly above normal. The clone size also plays into effect. So yeah, we do have certain metrics that, again, that usually do kind of combine a lot of these lab values.
Thank you. This is was sent in for Dr. Tantravahi. What is meant by relapsed aplastic anemia? Why does a patient relapse? What are the treatment options for relapsed aplastic anemia?
Yeah, so essentially what we mean by relapse is that the disease coming back again. The way it shows up is a decline in the blood counts. So someone has already been treated, let's say, for example, ATG, and had a good response, and after a while became anemic or drop in platelet counts again. So that's kind of considered relapse is basically essentially the disease has come back. By nature, autoimmune diseases do tend to fluctuate. That means there are remissions, which means that the disease is not very active and the blood cell production is maintained in that situation, or the disease can flare where the disease is really active and the immune system is essentially completely destroying the bone marrow. So in that situation, one wouldn't have any blood counts. So how you deal with the relapse diseases depends upon a variety of factors, as I outlined in my talk. Let's say if somebody is young and but don't have a family donor, and we've treated with ATG, and if the disease comes back and they develop low blood counts again, in that situation, we would, if there is a donor from an unrelated registry, then that's what we would recommend, doing a stem cell transplant. Whereas in other situations where transplant is not an option, either because of lack of donor or due to age and other medical health problems, then we rely on some of the medical treatments that I outlined. And majority of the medical treatments are either suppressing the immune system with so-called immunosuppressive medications, or we now have drugs like eltrombopag. There's another drug called romiplastim, which I didn't talk about too much. So both eltrombopag and romiplastim, both of them have shown to stimulate the blood stem cells and increase the production of blood cells. So both of these drugs have been used either on their own or in combination with some immunosuppression to treat when the disease comes back, where transplant is not an option.
Thank you. Next question is for Dr. Nestor. Is treatment for PNH lifelong? If yes, why?
Yes, especially with these complement inhibitors, because really what we're trying to do is we're not changing the actual cells themselves. We're just trying to give a layer of protection to those cells that have otherwise lost it. But the bone marrow, at least when we're treating with our complement inhibitors, are still going to be producing those same cells that have the lack of those protective CD molecules on the outside of their surface. So without being able to change what's going on in the bone marrow, those very, very first clones that are producing these downstream red blood cells, platelets, granulocytes, they're going to continue to create those. So no, it's not a reversible process outside of a bone marrow transplant.
Thank you. And next question for Dr. Tanchvahi. Can you talk about FMT research for aplastic anemia?
What is FMT? Can you repeat that? FMT?
Can you talk about FMT research for aplastic anemia?
I'm not so sure what that stands for, but I can talk about in general, what we're trying to do in terms of research in aplastic anemia. In most patients, it is not known what triggers the aplastic anemia. We know it's autoimmune, but why do some patients develop this disease whereas others don't? And for example, geographically, there's an increased rates of aplastic anemia, for example, in Southeast Asia. And it is believed to be because of the higher rates of these hepatitis virus infections from either contaminated water. And these viruses don't necessarily directly cause the disease, but they somehow sort of manipulate the immune system in a way that your body now recognizes the blood stem cells as foreign. But now there's increasing amount of research done on like specific HLA molecules, people who have a specific type of HLA, which is essentially a protein that is present on the stem cells, they're more likely to develop aplastic anemia. And again, there are also specific HLA molecules that also been shown to sort of more likely to respond to ATG. So the research, majority of the research is done in that regard. And then the other field where we're trying to understand is that what causes the clonal evolution. why some patients with aplastic anemia tend to develop more like a leukemia down the line. And that's been because now we have sequencing technologies available. We can actually detect low-level mutations in genes, in the same genes that patients with leukemias have in aplastic anemia patients, even at the time of initial diagnosis, and they tend to expand over time. So there's a lot more research being done to understand why this so-called clonal evolution happens in that patients. And then we're also trying to understand more genetic reasons for an inherited cause of bone marrow failure, like I had talked about earlier.
Thank you.
Yeah, I got to go look up what FMT is.
Okay.
Okay.
And another question for you is, somebody said, my son has non-severe aplastic anemia that appears to be autoimmune. His blood counts aren't severe enough for transfusions. Would you ever recommend the ATG medication in that situation?
That's a great question. I think I did talk a little bit about non-severe aplastic anemia. So there are patients with non-severe aplastic anemia that are still sick. That means either they have symptoms because of anemia, or infections because of low white cells, or the platelets are low. So in those situations, treatment is justified. But there are situations where somehow you recognize aplastic anemia very early because they've had a blood count done and then had more testing done. And if the blood counts are in a decent range and not causing too much compromise in the quality of life, it is reasonable to keep track of it and not necessarily do treatment and intervene only when the counts get worse. But that's relatively sort of an uncommon situation. But if diagnosed early for some reason, but the counts are stable, it's perfectly justifiable to keep track of it. And I have had patients who had very mild anemia and mild decrease in platelets, and when we do a bone marrow, the bone marrow is replaced by fat. And somehow they maintain blood cell production, and these patients don't necessarily require treatment until the blood counts get worse.
Thank you.
I want to jump back just really quick on the FMT. I do want to point out that this fecal microbiome is actually an area of research. We have a researcher at UNMC that's looking at what kind of bacteria are living in the gut, and those different bacteria can activate the immune systems in different ways. And so there's a question about what kind of things might be happening in the gut that could affect things like outcomes in transplant. So it is interesting that yes, we are kind of looking at even things like your digestive system and all the ways that those immune stimulators can affect the body.
Thank you both. Another question is, if you get aplastic anemia from drug therapy, are there other drug therapies to cure it?
I can take that question. Yeah, so there are specific medications, drugs that are known to cause aplastic anemia. The classic example is this antibiotic called chloramphenicol, and we don't use that drug anymore. But there are other, now there's so much sort of what we call as targeted therapy in the field of cancer. And some of these medications that are used to treat other cancers can suppress bone marrow and sort of cause something similar to aplastic anemia. Majority of the times, these it is a reversible process. That means the offending agent, once you stop it, the bone marrow is expected to recover over time and blood counts get better. But I've had situations where people have developed so-called drug-induced aplastic anemia, but the counts don't get better even after you stop. In those situations, I look for sort of evidence of autoimmunity, like I had talked about, having a small PNH clone and that kind of stuff. And some patients I have treated with either immunosuppression drugs, sometimes ATG or L-Trombopag to accelerate the recovery of the bone marrow. So there are some patients with drug-induced aplastic anemia that may require treatment because the counts may not improve after stopping the offending agent.
Thank you. We have more questions online, but I wanted to know if anybody in the audience had any questions.
Well, I have multiples, but I'll try and boil it. Well, oh, sorry. Hi. I'm a long-term survivor of both aplastic anemia and PNH. Years ago in the early 70s when they first started bone marrow transplants, it was an all or nothing, and they needed something below 20% match, and I didn't have that in my siblings, okay? And they didn't have the bone marrow registry then, they do now. Today, if somebody gets a transplant and it doesn't take, is it automatically an X out, or are there alternatives, i.e., and this is another thing, I've got friends that had some types of cancer and they do autologous bone marrow transplants. Is autologous, even though you've got a damaged bone marrow system, autologous a possible situation for aplasia? Sorry.
I'll take the first attempt, and then I'll have Dr. Next to speak. A full confession, I'm not a transplanter, so I want to answer the second question, which is autologous transplant. Yes. It's not a treatment for either aplastic anemia or PNH. The reason being is that in aplastic anemia, we have very much deficient in blood cell production. The amount of stem cells in the bone marrow are very minimal. Right. So the ability to harvest these stem cells doesn't exist. And whereas in PNH, these stem cells are defective, they have a PGA mutation and can make that protein that protect your red cells from the complement attack. So in both situations, by mechanism, autologous transplant is already ruled out. In terms of you've talked about, HLA typing has, with the ability to be able to sequence deeper, we now can do this so-called deep, sequencing to match for the HLA. And with the, nowadays, not having a donor for somebody who needs a transplant is rather rare situation.
Is it still like 1 to 100,000 ratio for a non-related person? Is that
I don't know the exact ratio. It depends on sort of your ethnic and racial background. Because the NNDP registry is well established in the Western countries, most Caucasian white background have 60 to 80% chance of having a donor. But now that we figured out a way to do haplotransplant, which a half-match transplant in a safe way, nowadays there's always the situation where you don't have a donor is far less.
you can find one?
Yeah, you can find one because we can do half-match transplant in a much safer way these days as compared to 20 years ago.
But it still requires you to wipe out, it still requires you to wipe out your existing bone marrow to take on the new stuff.
Yeah. So in the context of aplastic anemia, the so-called conditioning regimen before transplant, yes, what it's doing is it's basically getting rid of the immune system so that you don't reject the graft. So that's kind of the reason why you still need, there's one exception, which is even in that, there's only reason you don't need anything before transplant is someone has immunodeficiency and they have a perfect match twin. So that may be the only reason where somebody doesn't need anything before getting a donor cells. Dr. Ness, do you have any?
I just have to hijack for a quick second. The issue of things like the availability of folks to find a match on the bone marrow registry really does depend on kind of ethnicity and backgrounds and whatnot. In a lot of cases for things like sickle cell disease, these people will have the same mutation in other family members, so then they have to go out and look for a national registry. But unfortunately, just due to discrepancies in access to medical care and whatnot, it's very hard to find good matches. So I strongly encourage people who are people of color to go out and talk about getting their bone marrow registered to help other people.
Thank you. Does anybody else in the audience have any questions? Okay, we're going to continue with our online questions. All right, our next question asks, what are the issues around airplane travel with severe aplastic anemia?
Specifically with aplastic anemia and airplane travel, I don't think there's any issues. The only time I advise caution in patients with aplastic anemia is when they have severe neutropenia, which is basically low neutrophils, which are part of the infection-fighting cells, so they're higher risk of infections. In that situation, we often advise caution. But other than that, other than common sense, particularly if someone had a transplant, then travel sometimes can increase the risk of getting an infection. Other than that, I don't foresee any particular reason not to travel when someone has aplastic anemia. I often have patients who travel from elsewhere to get a second opinion. So do you have any other comments on this?
No, again, I just the only things I could think from a PNH standpoint, there's some thought that airline travel can increase the risk of blood clots, but that's kind of a general rule. I wouldn't tell anyone with PNH, don't be on an airplane. But then I would also second that again, with those low white blood cell counts, we worry about infection risk. A lot of people, and so we kind of expect, it can't be around a lot of big crowds. But a lot of times the bacteria that are affecting us are actually from your own body. But again, if I was on a big plane with 300 people and the person on my left and right were coughing on me, that could turn into a cold to turn into a pneumonia. So yeah, I agree, just kind of common sense, washing your hands, don't hang out with sick people.
Thank you, Dr. Nestor. You actually answered my other question. What's our last question? So our last question is, do you want to ask your?
When a patient is dual diagnosed with aplastic anemia and PNH, how do you know which disease to treat? And how often should an aplastic anemia patient be tested for PNH?
Majority of the patients, or some of the patients with aplastic anemia, have a very small PNH clone, and it basically a surrogate marker for an autoimmune attack on the bone marrow. And these patients don't need any treatment for PNH. And then on the other hand, these patients with classical PNH, where there's a big PNH clone, and their clinical manifestations are predominantly because of the breakage of red cells in the bloodstream. And there you need PNH-based treatment. But there's always some patients who have an overlap in between. There are those patients who has bone marrow failure, but also have some degree of hemolysis because of a decent sized PNH clone. So in those patients, there are situations where you have to use treatment with both complement inhibition, which are C5 inhibitors, which is what we use these for PNH now, and also immunosuppression on ATG to treat the aplastic anemia. So yes, there are patients who may need treatments for both, but sort of less common. Mostly they're patients on either end of the spectrum, if full-blown PNH or full-blown marrow failure with a small PNH clone. In terms of how often you monitor, that's a great question, because There are patients with aplastic anemia who have a small PNH clone, and that can expand over time. And let's say they've received immunosuppressive treatment and had normal blood counts. I've had patients where after a few years, they present with what looks like a full-blown PNH. So I tend to repeat flow cytometry for PNH clone in these patients with aplastic anemia survivors at least once a year, and also watch out for symptoms of the PNH that Dr. Nest has elegantly described.
Yeah.
Dr. Nest?
I think that it is a part of it is serial management. The bone and that combination of both the actual view of the bone marrow and the cellularity of the bone marrow versus that PNH clone, and those can change over time. And as of right now, I don't think that we have a really good way of kind of determining how people are going to be spinning off, whether or not they are going to have a PNH clone that's going to progress rapidly. I think that that's still an area that is under additional study. There's some question of if the granulocytes, in particular, more so than the red blood cells, have this PNH clone, that may suggest that the PNH may actually progress a little bit more, but we're not quite sure.
Dr. Nestor, can PNH patients also develop MDS? And if that is the case, would then a potential transplant be an option to cure both diseases?
I don't know that PNH is considered a major risk factor for MDS, at least not on kind of the classical, in which our problem is mostly peripheral. Because like we saw on that bone marrow slide, the hematopoiesis in classical PNH is still actually relatively well ordered. These cells are being manufactured just fine. The development of MDS is usually because of some kind of prolonged DNA damage, which is why we see it in older folks and with certain higher risk exposures like chemotherapy. Provided that there's nothing in that PNH that's actually acutely attacking that DNA in the bone marrow, I don't know that I would watch super closely for MDS. I mean, that's not to say that nothing reads the book, though, so.
I'll just have one more comment. I agree that PNH itself is not a risk factor for MDS. You don't expect with full-blown PNH to develop MDS down the line. But what is also known is that there are patients with low-risk MDS. That means they have a diagnosis of MDS, and some of these patients have a small PNH clone. And the small PNH clone in the context of MDS seems to affect more within the low-risk disease, where you don't necessarily treat and monitor, and some patients may need treatment for anemia. But PNH clones are very uncommon in high-risk MDS. If that, having a small clone to a full clinical PNH is a distinction we're trying to make here.
Thank you. And I know Dr. Gundabalu is going to talk about transplant in the next session, but for PNH, since we're discussing PNH, when would a PNH patient look to consider a transplant? Under what circumstances? With the wonderful drug therapies we have now, there's still patients who suffer for breakthrough hemolysis, which can't be controlled, but under what circumstances would a patient look at transplant?
Yeah, if we're seeing that cellularity in the bone marrow, or maybe if we're starting to see that the bone marrow is not able to keep up with things like breakthrough hemolysis. Of course, it also depends on the patient. If someone was young and was having trouble on their initial complement inhibition, then I would be more likely to talk about transplant with that patient sooner.
And Dr. Nestor, do you see a future for oral therapies for PNH?
Oral therapies?
Yes.
We're hoping, absolutely. The main question is just, what the actual structure of the drug looks like. Our antibody therapies are proliferant because we are able to make antibodies against pretty much any protein or cell that we want to nowadays. but you can't really ingest antibody. It would be broken down. And so that's why we have to do IV therapy or subcutaneous therapy. Some of these other therapies that may just directly inhibit those proteins, they may be small molecules that have nothing to do with, they're not made of proteins and whatnot, and so they would be able to pass through orally. But again, we haven't quite found quite so many yet. Part of that, I think, is that when we're looking at how the complement pathway kind of passes through, it's usually looking for certain targets. So a lot of times, such as with that pegylated therapy that targets C3, that's able to kind of wedge itself a little bit into an important target site. On the other hand, some of those more regulatory proteins, we may have a drug that's able to kind of just rub up against the molecule. Drug development is a very complicated issue, and part of it is just whether or not you're targeting something that you can push in or rub to the side of the given protein and make it stop working. And sometimes we just haven't found a way to do that yet.
So thank you for a great talk. Really enjoyed both the talks. I have two questions. One is, you at times see patients with myelodysplastic syndrome or previously treated with immunosuppressive therapy, and they're followed along for their PNH clones, and some of these patients evolve without hemolysis. In other sense, the red cell clone size is quite small to a point where they don't have clinical evidence of hemolysis, or at least meaningful amount of hemolysis, but yet they have a large granulocyte clone or a monocyte clone. I often struggle in clinic, when should you think about starting them on complement inhibiting therapy? So is there a magic number? Number one. The second question I have, and certainly I want to highlight this also, is what sort of immunizations patients have to receive when they are on complement inhibiting therapies, particularly they're on lifelong complement inhibiting therapies in the West. And are there any other, antibiotics or so forth you have to take into consideration in certain instances to reduce the risk of infections, and what sort of infections are common? Thank you.
We will use complement blockade again with hemolysis. Classical NPH can actually be based on the granulocyte clone as well, not just the RBC clone. Complement inhibition can be used if the thrombosis is associated with the PNH. So even if there wasn't a substantial amount of hemolysis, if we had one of those atypical blood clots, that would be an indication for putting people on therapy. Again, the main things that we are concerned about in terms of an infectious risk for these complement blockades, the real main one is this Neisseria meningitidis. It's actually, unfortunately, relatively common in certain populations. The classical things are things like college students and whatnot. And so a lot of times people who are heading into college or the military will get a couple of different vaccinations, including the meningitis vaccine, which as well as a booster that targets a specific substrain, meningitis B. Those are required, and then oftentimes we'll also add something against Haemophilus influenza B, which also is an encapsulated organism. Generally, the antibiotic we'll oftentimes choose is a fluoroquinolone, so something like Levaquin. And generally, a lot of other times we'll consider putting people on prophylactic therapies for like viruses, including herpes, or certain funguses. But generally, that's going to be more in the aplastic anemia, where you're losing things like T cells and you're inhibiting those T cell activities. Not quite as big a problem in NPH. It really is more of that bacterial problem.
I'll make one comment on the context of MDS and PNH clones that Dr. G was talking about. So the patients with MDS who have a small PNH clone, they don't necessarily benefit from complement inhibition unless they have a clone size of typically more than 30%, there's no magic number, and have symptoms of PNH, either intravascular hemolysis and another sort of symptoms suggestive of this nitric oxide depletion from hemolysis. But what it also could mean is that some of these patients with MDS and a PNH clone, and if they have severe cytopenias, they may respond to immunosuppression. So I've treated patients even though there's a diagnosis of MDS and they have a PNH clone, with more like immunosuppression, either cyclosporin and L-trombopag, and had a really good response. So bottom line is that PNH clone in that context suggests that there may be an autoimmune-mediated component that you can leverage with immunosuppression to improve the blood counts. And in terms of the oral drugs, I'm actually super excited for various reasons. Because one is, particularly in countries like India, where you see PNH, oral drugs, I think, can be a magic, because these people are out there somewhere, and it's not feasible to travel somewhere to get an IV treatment every 2 weeks or every 8 weeks with ravulizumab. So I think that's going to change the landscape. The one downside of the oral, as you can imagine, is it depends on your compliance. If you don't take it, you're not going to respond. But most non-compliant people, they're not going to show up to the infusion room anyway to get their injection. So I think it's really exciting, these new drugs, and the drug, the iptacopan, that was presented in recent ASH is very effective. So it's very exciting to have new drugs that you can because we've been treating CML with Gleevec. There are a number of patients on Gleevec and are still living. So I think these oral agents can be a real progress for many patients with PNH.
Thank you, Dr. Nestor and Dr. Tantrapati, for sharing your time and expertise with us. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking the replay button by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call the AAMDSIF helpline at 800-747-2820, or you could submit a question on our Facebook page, www.facebook.com/AAMDS. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan for future educational programming. Also, be sure to visit the exhibit hall and chat with our conference sponsors. The next educational sessions will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice. For information on bone marrow failure diseases, the AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 40 years. This concludes the session.
Thank you, everyone.
Thank you.